Hello, Holistic. Our topic today will be neck pain. These are the objectives that we'll be going through during our presentation. Neck pain comprises around 14.6% out of the total pain in different joints, migraine, headaches, and lower back. Causes of neck pain. Common causes such as muscle sprain, herniated nucleus pulposus, degenerative disc disease, annular fissure or tear, zygovascular joint arthropathy, spinal central or foraminal stenosis. Also, rare but important causes of neck pain, epidural abscess, hematoma, discitis, osteomyelitis, primary or metastatic cancer. These are the red flags that every practitioner should be aware of. For example, sudden onset of a new severe headache, a worsening pattern of a pre-existing headache, headache associated with fever, neck stiffness, skin rash, and with a history of cancer, HIV, or other systemic illnesses, headache associated with focal neurologic signs, moderate or severe headache triggered by cough, exertion, or bearing down, and new onset of headache during or following pregnancy. We'll be talking first about a kind of an algorithm that we'll be approaching today um, for neck pain. First, the word algorithm means a step-by-step procedure for solving a mathematical problem in a limited number of steps. And this science was developed by scientist. His name is Al-Khwarizmi. And the Germans kind of changed his name to Algorithmus for ease of pronunciation. Similar to a lumbar spine algorithm, cervical spine algorithm is made up of 3 steps. Step 1, 2, and 3. Step 1, basically conservative management. Step 2, spinal injections. Step 3, neurosurgical interventions. Again, like lumbar spine algorithm, we'll start with the conservative, then we divide it into 2, neck pain algorithm, radiculopathy algorithm, and eventually patient might need neurosurgical intervention. Conservative measures include education, psychotherapy, physical therapy, especially what we call McKenzie approach. This is very important for cervical neck pain here. Trigger point injections, acupuncture, TENS unit, foam collar, and drug therapy. These are the different cervical spinal injections that you might encounter during your practice here. Cervical interlaminar, transfemoral epidural, atlanto-occipital, atlanto-axial, cervical facet and joint and medial branch injection, cervical epidural lysis of adhesions, conventional or pulse radiofrequency, greater occipital nerve block and stimulation, dorsal root ganglion pulse radiofrequency, dorsal column stimulation, dorsal column ganglion stimulation, intrathecal drug delivery. As we talked about, in our lower back pain presentation, you might have false positives while doing the injection, what we call placebo. And actually, it happens in 30% of the patients. And you can also have false negative results from these injections if you're placing the needle in an incorrect position. Spinal injections are both diagnostic and therapeutic at the same time. Some of the neurosurgical procedures that you should be aware of is ACDF, which is basically anterior cervical discectomy and fusion, cervical foraminotomy, cervical laminectomy. Whiplash injuries. According to Quebec Task Force, they defined whiplash as a bony or soft tissue injury as a result of rear end or side impact in road traffic accidents, and from other injuries resulting in acceleration deceleration mechanism of energy transfer to the cervical spine. The Quebec Task Force proposed a classification system to define the severity of whiplash injury. Stage 1 or grade 1, patient complains of neck pain and tenderness. Grade 2, patients exhibits musculoskeletal signs, including decreased range of motion and point tenderness. Grade 3, the patient shows neurologic signs, including sensory deficits and decreased tendon reflexes and muscle weakness. Grade 4, the patient has a fracture, acceleration, deceleration injury. Cervicogenic headache is basically related to atlanto-occipital joint disease, atlanto-axial joint disease, C2 3 facet, C2-3 cervical disc disease, and myofascial pain disorders. All of these can cause cervicogenic headaches. Again, atlanto-occipital, lateral, atlanto-axial, xiphovertebraal, intervertebral disc as well. C2-3 intervertebral disc. Diagnostic criteria for cervicogenic headache: pain localized in the neck and occiput, which can spread to other areas in the head, or such as forehead, for example. Pain is precipitated or aggravated by specific neck movements. And then you have other things you can add, such as resistance to limitation of passive neck movements, abnormal tenderness of neck musculature. With radiology, movement abnormalities in flexion and extension, or abnormal posture. Cervicogenic headache compared to migraine and tension headache, female to male is 1-to-1, usually unilateral, occipital to frontoparietal, chronic and episodic, duration 1 hour to weeks. Pain characteristics: non-throbbing and non-lancinating. Pain usually starts in the neck movement, and postures trigger the pain. Limited range of motion, pressure over CO to C3. Associated symptoms usually absent or similar to migraine but milder. Cervical discogenic pain syndrome, CDPS. Prevalence is somewhere between 16 to 41%. The commonly affected levels are C5, 6, and C6, 7. With C7, a nerve root is the commonest nerve root involved in the neck. Disc denervation. The posterior aspect of the disc is innervated by the sinovertebral nerve, while the anterolateral aspect is innervated by gray ramus communicans, very similar to the lumbar area. Sinovertebral nerve and gray ramus communicans for the anterolateral part. Sinovertebral nerve for the posterior aspect of the disc. Some clinically, approved provocative tests here for the neck is Sperling test, Lermit sign, shoulder abduction relief sign. So with the Sperling test, you exert a pressure on the top of the head while you're extending and rotating the head. Shoulder abduction test, patient puts his hand over the top of his head, and usually this relieves the pain, as you see here. A positive test is relief or decrease of the radicular pain with this maneuver and may be indicative of cervical radiculopathy. The Lermit sign is basically an electric shock sensation, which occurs with neck flexion and often radiates to the spine. Evaluation. Radiographic imaging is usually indicated in patients with a history of trauma or if there's any concern of possible fracture. In cervical discogenic pain syndrome, radiographic findings may be normal. It may show degenerative changes, but there is a little correlation with symptomatic versus asymptomatic individuals based on these findings. The combination of clinical symptoms, MRI, and cervical provocative discography can help with the diagnosis. Cervical discogram is done from AP view, not like the discogram in the thoracic or the lumbar. Types of disc herniation. We have a bulge, we have extrusion, we have a prolapse or rupture, and then we have sequestered three fragments. Mixter and Barr are the founders of, the ruptured disc syndrome. And this was back in 1934. These folks, they published an article about the rupture of the intervertebral disc with involvement of the spinal canal. There's a difference between the cervical spine and the lumbar spine. With the cervical spine, the disc basically presses on the nerve root, coming out of the neural foramen here. So C6-7, for example, is pushing in the C7, only one nerve root. While with lumbar disc herniation, it depends on the location. If it's paracentral, here, for example, for the L4, L5, it's pushing on the L5, while the far lateral disc can push on the L4. This is a very important distinction between cervical spine and lumbar spine. And as we said, C7 is the commonest nerve root involved, and the C6-7 disc is the commonest disc involved in the cervical spine. These are some, neurologic examinations for different nerve roots, okay? Cervical facet arthropathy, common after whiplash injuries, C2-3 and C5-6 are the commonest sites. Pain on extension and lateral bending. The atlantoaxial and atlanto-occipital joints, they don't have medial branches, and thus we inject the joint directly. Atlanto-occipital, atlanto-axial joints, these are under diagnosed in the pain field. The atlanto-occipital and the atlanto-axial are associated with suboccipital pain that is aggravated by lateral rotation of the cervical spine and flexion extension of the cervical spine. Unfortunately, this can persist beyond 2 to 4 week period or with conservative measure. And once you have chronic manifestations of atlanto-occipital, atlanto-axial joint, pain, you need to start injecting these joints. Atlanto-occipital, and this is the atlanto-axial. Okay, this is the atlas, this is the axis, this is the occipital. And you see here the danger of injecting these joints is you're very near to the vertebral artery. This is the biggest challenge. Of course, you're also near to the spinal cord. You have to do it under C-arm, and you have to take all precautions for resuscitation if anything happens here. And try to avoid particulate steroids so you don't clog the vertebral artery. Atlanto-occipital, atlanto-axial joint injections. Cervical facet innervation. This is pretty straightforward, except the C2-3 is supplied by the TON or the third occipital nerve and the C3 nerve. All the medial branches are located at the waist of the cervical cervical body here. So, for example, we mentioned that one of the commonest areas are C5-6. These are supplied by, this is like C5-6 is here. This is supplied by the medial branch of C5, medial branch of C6. Again, C5-6 basically present with pain on the shoulder, while C2-3 present with pain in the suboccipital area. This is the test all of us do for facet disease. We call it the Kemp test or quadrant test or external rotation test. I like the name extension rotation test. There's a lot of controversy about this test in the literature, and the research has shown that it has low sensitivity and specificity, but we still do it. You can actually use the information with other information like history, palpation, radiologic pictures. All together can help out with even the injections. As we said, could be diagnostic as well. Cervical medial branch, you stick the needle in the middle of this parallelogram. Okay. Now, You can do this procedure from lateral view, or you can do it AP. It depends on how much you're comfortable. C7 is a little bit different than the rest of these, and you basically go a little bit higher. Also, C23 or the thumb nerve, uh, is located somewhere here in the upper part of C23. Cervical dystonia is a rare entity um, that can resolve without treatment. 82% present with torticollis, 42 with latericollis, 25% with antericollis, and 29% with retrocollis. Dystonia can affect any part of the body, like blepharospasm. It can cause a laryngeal dystonia, a writer's cramp, or even generalized dystonia. And the management is basically muscle relaxants and botulinum toxin type A or type B. Uh, as you know, botulinum toxin inhibits the presynaptic release of nociceptive peptides and acetylcholine. Maximum dose per setting is 300 units to be repeated every 3 months. Another thing that you can try is the deep brain stimulation. And usually these surgeries um, are basically reserved for what we call functional neurosurgeon. Not all the neurosurgeon can do this type of operation. Myofascial pain disorder can give you a chronic and acute neck pain, such as semispinalis capitis. Semispinalis splenius capitis, splenius cervicis, sternocleidomastoid, suboccipital muscles, temporalis, upper trapezius, sternomastoid. I mean, it looks very similar to, someone having migraine headache. Levator scapulae, rhomboid, trapezius. Again, gives you a picture of migraine headache. Neck tongue syndrome is basically a rare disease characterized by unilateral neck pain and numbness at one side of the tongue. And the theory beyond this disease is basically entrapment of C2 nerve root. And it's treated basically with gabapentoids. Upper cervical instability can cause many problems, in your body here, including, cervical dystonia. It can cause compression of the carotid sheath, postural orthostatic tachycardia syndrome, cervical spinal cord tension, vertebral basilar insufficiency. So whenever you have these kind of symptoms that came from nowhere, you really need to address whether this patient has cervical instability or not. And you can do a test on the X-ray. They can check it out for you, and the flexion extension positions here. One of these diseases is called Barré-Loux syndrome, and basically manifested with autonomic symptoms such as uh, tinnitus, vertigo, sinus congestion, severe fatigue, and this is related to cervical instability and affecting, the autonomic chain in front of the spine. Malignant spinal cord compression. It's a common problem in advanced cancer, with 5 to 10% of patients are having malignant spinal cord compression. Mainly affects the thoracic spine 70%, less so with lumbosacral 20%, and 10% in the cervical spine. MRI is the imaging modality of choice because of its high sensitivity and specificity, because symptoms poorly correlate with the compression level, and spinal cord compression can occur at multiple levels simultaneously. Imaging of the entire spine is recommended. So whenever you suspect malignant spinal cord compression, you have to order a whole spine MRI. Malignant spinal cord compression before and after surgery. Cervical epidural steroid injections, okay, these are very useful in radicular pain, and we usually do the interlaminar cervical epidural, below C7, so C7 T1 or T1 T2, to avoid, injuring the subarachnoid space. Cervical transforaminal, if you have a localized radicular pain, be careful, do not use except soluble agents such as dexamethasone, and also it needs a special type of CR that can pick up, vascular intake of contrast. Since this biggest problem with this procedure is you inject in the radicular vessels that's supplying, the spinal cord. Another procedure developed by Gabor Rex. He's one of the famous pain physicians, and he's the president of World Institute of Pain. With epidural lysis of adhesions, you thread a Rex catheter using a Coday needle, and you do an epidurogram, inject hyaluronidase to dissolve the gram substance, and then you inject local with steroids, followed by hypertonic saline to reduce the swelling and provide long-term analgesia. These are the selection criteria for epidural lysis of adhesions. I would say the most important one is the failed neck surgery syndrome. Coday needle, Rex catheter. This is the Coday needle, and this is the Rex catheter inserted at the level of T1, T2. Again, we choose either C7 T1 or T1 T2 because you have an abundant space here before you reach the epidural space. With higher levels, you can easily puncture the dura and get in the subarachnoid space. Occipital neuralgia is occipital pain on one side. Let me put it this way. You have the nausea when the pain is severe. And these patients manifest severe light sensitivity and pain above and behind the eye. Sometimes it gets confused with migraine headaches. All right. The main distinction is the block. When you block it, the pain goes away. Um, Atlanto-occipital atlantoaxial. Actually, it should be the opposite. Atlanto-occipital here, atlantoaxial is over here. Okay, greater occipital nerve block is a very important block for pain interventionists. Uh, you can do the distal approach or you do the proximal approach. With the proximal approach, it's suboccipital and you have to do with ultrasound. Otherwise, you can get easily inside the thecal sac. The distal approach, there is bone below the nerve. So the worst scenario, you touch the nerve. Occipital nerve stimulation is basically the one type of peripheral nerve stimulation to the occipital nerve. Percutaneous vertebroplasty is another procedure we use for osteoporotic compression fractures or malignant destruction of vertebrae or painful aggressive hemangioma or vertebral fracture associated with osteonecrosis. Your approach is very similar to the disc approach. You go from the front and you stick the needle and vertebral body, and then you do your routine injections with cement. Spinal cord stimulation. The first two guys that came out with the idea of gate theory were Melzack and Wall. Melzack was from Canada, Wall from Patrick Wall from UK, and they won the Nobel Prize for the gate theory in 1964. Um, Gate theory is a fundamental theory in pain management, and in short means that if you're stimulating large fibers such as A beta fibers, this will block a gate that can transmit pain impulses from the C fibers. Dr. Norman Shealy took over this gate theory and he developed TENS units and spinal cord stimulators. This guy just passed away in July. I mean, he's considered the founder of neuromodulation. Selection criteria for implantables, like dorsal column stimulation. Failed conservative measures, failed spinal injections, psychological screening is appropriate, and successful trial. Before you attempt to buy, any spinal cord stimulator, you need to ask the rep about these 5 things. Current versus voltage. Tonic stimulation, is it high frequency stimulation? Is it burst stimulation? Is it high density stimulation? This is the wave delivered. This is the amplitude. This is the duration. If you have a long duration and high amplitude, you have a high density stimulation. If you're having frequent waves, this is called high frequency stimulation. While the constant current or constant voltage represent the power source. And they say that the current is more tolerable than the voltage. So this is the burst spinal cord stimulation, and this one is the high frequency spinal cord stimulation. As you see, very frequent. The burst is basically you get a burst and then there's silence and then another burst. And this is similar to what's happening in our nerve tissue inside in vivo. And that's why the burst stimulation is considered the nearest type of stimulation, nearest one to human beings. Tonic stimulation, this is the traditional one, and burst stimulation. The pulse width is 1,000 microseconds, and it delivers 5 pulses per burst. Anyway, the difference between tonic or the traditional and the burst is on, the neurotransmitters. With the tonic, the neurotransmitter is GABA B, as in boy. And this is the receptor that baclofen works on, a very famous muscle relaxer, baclofen. While the burst is non-GABA B dependent. And thus, if you have a tonic spinal cord stimulator and it's weaning off, you can add some baclofen, and this will help the stimulator. Cervical dorsal column stimulation under X-ray. See how nice it's placed. DRG stimulation or dorsal root ganglion stimulation. In this form of stimulation, we try to get as near as possible to the dorsal root ganglion. This has 5 advantages. First, directed targeting. Make it effective in 94.5% of the patients. Low energy, less than 10% of the energy that's required from a conventional spinal cord stimulator. This will actually allow the batteries, to stay longer. Lower risk of lead migration. It's been reported less than 1% migration rate, whereas traditional spinal cord stimulation reports an approximate 14% of migration. Minimal effects on body position. So the nice thing about DRG stimulation, it's not affected by movement of the neck or the torso. Pulsed radio frequency is a great modality, for dorsal root ganglia. Now, pulsed radio frequency gives you pulse wave and low temperature, less than 42 degrees, which actually doesn't cause neural destruction. It kind of magnetizes the nerve, more or less. So it's useful in areas where you're afraid to burn this nerve for so many reasons. Like if you're having a mixed nerve that has sensory and motor, you don't want to, like the greater occipital nerve, for example, has sensory and motor. If you use a conventional radio frequency it can affect the muscles that's supplied by this nerve. DRG pulse radio frequency. This is a comparison between the conventional RF, pulsed RF, and a recently introduced, a procedure. It's called cryoneurolysis. Cryoneurolysis has been used for decades, but there's been a revolutionary, a change in the size or the caliber of the needles. We used to use 14 gauge needle to do a cryoablation. So it really wasn't that practical. So we used cryoneurolysis and actually with smaller gauge needles, like 22 gauge and so forth. Intrathecal drug delivery systems are used in axial pain. Now, someone will ask me, so where are we going to place, the pump? Well, you're going to place it like you place any pump. Okay, you put the receiver either in the gluteal region or the lower quadrant of the abdomen, and the catheter will go intrathecally till T11 area. Nothing different than the rest of the procedure that we do for malignancy or for, let us say, spasticity, same thing. Now, you might need higher doses. If you're, placing this pump for neck pain. Number two, you have to use agents that are hydrophilic, like morphine, so it can spread up, okay, and cover the neck area. I'm going to end with 3 famous surgeries for cervical discs here, such as anterior cervical discectomy and fusion, a very famous procedure by the name of ACDF. And as you can see, we actually fuse the 2 vertebrae together and do the discectomy at the same time. And this is the best operation for the neck to prevent cervical instability. Remember, I showed you this beautiful picture for the cervical instability, how it can affect your whole body, okay, from top to bottom. So this is a really serious problem. So when you do like laminectomy, for example, only there is a chance you get cervical instability, and this can cause a lot of issues in your body here. And lastly, cervical foraminotomy. This one widens up the cervical foramen. And this is for selected nerve roots. Key learning points for this presentation: chronic neck pain is multifactorial in its generators. A thorough history, physical examination coupled with properly selected diagnostic imaging, physical therapy, pharmacologic management, and successful interventional treatment algorithm should be followed. Thank you.